Good afternoon, everyone. And I hope you enjoyed the conference so far. And my watch tells me, and I enjoyed the conference. The reason is at 10:30, my heartbeat went fast. And I remember that's the moment I had a panic. The thinking about in the near future, we're going to have a lot of data about ourselves, and our physical data, our mental data, even our spiritual data available there. And maybe we can be mimic. Everyone can have data version of ourselves. This data version of ourselves will keep constantly tell us who you are, keep telling us, keep describing us, keep defining us, and tell us what to eat, when to sleep, what exercise we should to do, and tell us how to live. Now this is really panic. The second reason is we're talking about overall digital transforming, and we're just looking up, thinking so many things to be done, and so many things to learn. And our ladder is higher and higher, and then we're looking down, and so many is by next years, in next 5 years' time, 50% of health organizations are going to use AI. So we really have not many comfort zone left to us. So, okay, this is my third time to be Bangkok, and I have learned a bit about Bangkok. 8 million population, 42 public hospitals, 98 private hospitals, 4,000 clinics, and average one doctor looking after 975 citizens. And I also found Bangkok has 8 sister cities in China, including Shanghai. So I'm from Shanghai. I have been working with United Family Healthcare for 15 years, and with InterSystems for 12 years. So United Family Healthcare was founded in 1997, and by Ms. Roberta Lipson. We now have 7 hospitals, 17 satellite clinics in 7 different cities in China. Beijing is our capital, and Shanghai is the second most popular city in the world. Tianjin is a city close to Beijing, and Qingdao on the coast is a city belong to Shandong province, where Confucius from. Guangzhou is the capital of old name Canton. Okay. We use hub and spoke mode. The hub spoke mode is a terminology used in airline industry. Hub is airport, and spoke means the routines airplanes take off from the airport. And this is the map of Beijing, and we have 2 hospitals at the moment. One is acute hospital, the other is rehabilitation hospitals. Surrounding, there are 7 clinics which extend our service to community and basically provide easy access to our population. Our medical team from 34 different countries and regions. Overall, we have 400 full-time staff and about 1,000 medical consultants from local hospitals. We provide medical services for all stages of life, including preventative, acute care, and specialty care, rehabilitation, home care, and hospice. We're using track care, EMR, and basically recording all the medical practices and patient care transaction at transaction level, also driving clinical and business workflows. Okay. We are the first to implement primary care model, and in our Beijing hospital, we have Da Vinci robot to perform surgical procedures, and we provide integrated, comprehensive birthing model care. And in Tianjin Hospital, we practice IVF reproductive medicine. All our facilities are JCI accredited, and our lab in Beijing has CAP accreditation, and our EMR system had HIMSS MRAM 6 validated 2 years ago. I'm going to quickly talking about the stages of our implementation and clinical adoption. Our implementation started from 2009. As you imagine, we have experienced a lot of challenges. Cultural diversity. At the moment, we had physicians from more than 20 different countries and regions. We had legacy system in Beijing Hospital and Shanghai Hospital. We were required to replace our legacy systems and place track care in 2 hospitals, 5 clinics in 3 different cities within 2 years' time. And the language, we choose English, but we do need to implement a bilingual system. We selected ICD-10 for our diagnosis and the CPT for procedures, and the SNOMED for terminology, MIMS for drug interaction. Okay. We had many paper forms for different purpose, different version, and there was no good categorization and there was no good indexing system. The regulation supported EMR, but didn't support the paperless EMR. At that time, our mother company was sitting on NASDAQ stock market, so we have to apply SOX 404. SOX 404 is a financing auditing system for risk assessment acquired for a public company in the United States. And we had many doubts and panic from management as well as from our clinicians. People worried, what is the return of investment? And a system is able to implement it in such short time? Is that a possible system can up and running to support the daily clinical practice and the business process? Okay. Sorry. So we implemented the system, one database, and across all the facilities. We have real-time sharing, which means every time when patients step into a facility and all the medical record, lab results, reports, and notes, as well as all the medical history, medication history can be seen by physicians quickly. And when physician place an order, medication order, the order can be sent to pharmacy, real time, send it to nurse, for packing and administration in the real time. So all the alert and the details of medication can be easily seen and at the same time. We use the cloud technology for PACS, medical images can be seen anytime, anywhere. Okay. We use bilingual system, we partially translated ICD-10, CPT codes, and we didn't translate SNOMED. The reason is SNOMED, still haven't got agreement with Chinese government. So we are provider. We are not in the position to get this translated. So SNOMED is still single language. Okay. We implemented standards, clinical standards, as well as standards to manage our customizations. Of course, we identified many gaps between our needs as well as the system capability. So customize is essential to make implementation successful. But we do implement the standard control process to make sure the system is safe and every change in the system is safe. And also people working on the system follow the rules. We set up a very clear goal, which is the system has to be implemented within timeline. Any planned action support implementation, we will go ahead. Any planned action was not in line with the goal, we're going to put it on hold. We receive quite strong clinical governance from mainly 3 doctors. Our VP of Medical Affairs, Dr. Ruston, who was, before joining us, who was Deputy General Surgeon with government of the United States. So he basically provided us top-down governance. And CMO from Beijing Hospital, who's from Dr. Afnan, who's from UK, and before joining us, he led a team successfully delivered the 3rd IVF baby in the world. So his leadership style is more transformational, provide a good relationship setup. So he helped us to cut off noise, surrounding and give us a very good environment to continue implementation. Our CMO of Shanghai Hospital, Dr. Shao, is a Harvard graduate physician, and his style was more collective. He spoke for physicians and collect all the physicians' ideas. He did give us a little bit hard time, but a lot of good ideas came from Shanghai, was converted and implemented into the system. Okay. Okay. So everyone is familiar with this innovation life cycle. And when we step into hospital start implementation, usually we start with emergency because we do like emergency physicians. Most of them are action people, they take action quickly. So in Shanghai, we are very lucky. There's emergency physician was very good at leading, good at communicating and coaching. So we implement to emergency first, and we won that 2.5%. Now, then we move to internal medicine. Now, internal medicine is a little bit complicated, and the physicians have different thoughts. So we basically did 3 things. First is every day we release the completion rate, how many EMR you complete before end of the day, and we release that percentage every day. We set up a role model. I remember we identified a physician called Dr. George. He was quite a senior pediatrician, over 80 years old, and with one arm disabled. He still was able to complete EMR every day, 100%. And the third is to create peer pressure, especially in inpatient. Patients often transferred between wards and specialty as well as when their care level changed. So think about if patient partially, some doctors using electronic system, some doctors still writing on paper, and those use paper doctors were very much under pressure. They have to move to electronic. So, so that works. And I have a list of doctors who really complained a lot during implementation, after implementation, and I track them. And the one is very senior midwife, and I met her this year and in Guangzhou when we opened the hospital. I remember she was so difficult during implementation. Every single moment she complained to us, and linked to all the events, all the mistakes, near miss, as well as every single inefficiency action. So I saw her, and she was coaching new doctors. And instead of complaining, she talked about how important the system is and how good the system is. And she asked the new physician have to use the system. And she also told everyone she was the best user in the hospital. And we also, I also track another inpatient physician, and the doctor has left our organization and moved to another private healthcare organization. And he instead of complaining, and he really talking about the positive things about the track care and put a lot of effort to get track care into the new organization. Another example is one of our doctor in satellite clinic in Shanghai. And remember she was very difficult during implementation, and she closed door because she forgot all the training from holiday. She closed door and refused to see patient and want to resign. And I saw her just a few days ago in Shanghai. She was very happy, and the system is daily use, and there's nothing bad about the system. So we can see long term, we see the success, and we see the value created. The second stage we call clinical adoption. And during this stage, and we did the normal things. For instance, we're trying to improve efficiency and reduce variation. Of course, we're trying to bring data up and to figure out what's the best use of our data. But we also focus on 2 transformations. The first transformation is from doctor-centric to patient-centered. This is cartoon we seen often was also interpreted as a negative about EMR. Okay, after EMR implementation, doctor only looking at the computer, no more looking at the patient. Well, from the other perspective, we have to understand the physician, because before they have file, only one copy of file, only one person can access. Nowadays, in the computer, the physician can access at a different time, at any time, at the same time, and so much comprehensive data in the system. Not only notes, also results, as well as like critical values and handover reports. Everything is in computer, so doctor needs time to digest all this information. But this cartoon really reminds us medical practice is much more than queuing. Is a lot of important about comfort. The second transformation is the patient to person, and we understand that all the purpose of healthcare is to be healthy, and healthcare only contributes 10% of every individual's healthy status. And how can we maximize that 10%? Also integrate with the other components, for instance, the behavior and the social status as well as the environment, probably also plus spiritual and the mental health. Okay. When we're talking about the digitizing healthcare, and a few flows have to happen. Data has to flow, insight has to flow, and the care has to flow. And the financial, again, is very important. We're talking about value-based care, and everyone is sort of wishing we switch from volume-based to value-based is going to save a lot of cost. The fact is, measure value-based is very, very expensive. And what is the outcome? And clinical outcome and patient-reported outcome, we don't know how to measure well. And sometimes we don't even know what to measure. And the cost. And the most of hospitals, we don't know the cost. We know overall spending, but what's the cost for each care action, we have no idea. So how to measure, how data can help us move from measure-based care still require a lot of efforts. So at the time we're building transaction and the data for clinical care is also important to bear in mind. We can start thinking about the finance transaction. With the availability about good data and the good information, also the capability of predicting and the measure, we will be in better position to thinking about what is the health model and the business model for population health, and how can individualize the care, how can all this predictive power can really help our doctors. Thinking about in the clinic, and the physicians facing a cardiac patient, asking, okay, what is discussing, share the plan, what is the best approach to treat this patient, is stent necessary or not? If patient have different conditions, whether indication applies. No. Another example I've read is 50% of patients is going to have a complication after stent. And most of them don't know when this is going to happen. And if doctor can explain to the patient this is a percentage is going to lead a complication, and when this is going to happen, where is your percentile? All this kind of information is going to be very useful and helpful. Our challenges, again, we're facing cultural challenges. Our population has already changed. Chinese population already increased from 30% to 70%. And the local content needed to be rethink, because we know when patient population change, all the clinical guidelines need to be adjusted. For instance, we're talking about treatment for STEMI patient. And in up-to-date, recommend high-dose Lipto. However, in China, a lot of experts recommend low dosage. So which kind of guideline our organizing should use, we have to think about. Another example is like HP infection. HP infection is a high risk for gastric cancer. And in Japan, there's a screening. And if it is positive, and doctor's recommendation always kill bacteria, and there are different plans to kill the bacteria. And in China, this is optional. So therapeutic plan depends on symptoms and the size. And instead, on the other hand, in Europe, this infection is uncommon, even found positive, and normally physician is not going to treat, will get it naturally healed. Regulation compliance is getting more tough, and recently government released 12 points to each hospital. So every time government will come to inspect it, will see whether hospital comply or this regulation or not. If not, you will lose points. By the end of the year, if we lose more than 12 points, we are very much likely is going to lose practice license. Language, and we are in the position to switch from English to Chinese, and this really reminds us our free text data is going to getting very complex. If in the future we plan to use natural language processing, the whole process is going to be, complexity is going to doubled or tripled. Okay. Still, we use evidence-based practice, and we have subscribed many knowledge database. We put our up-to-date in EMR, so which will help our physician easy to get relevant information when they place order, when they place diagnosis, and getting treatment plan. We also set up a specialty network. The purpose of a specialty network is help doctors to communicate. In most of the time, doctor is very, very self-driven person, and putting them together to talk is not easy. So this network really help us to be able to define what is the best guidelines for institution, and what is the best workflow for our for daily process. For instance, in OB, we're trying to measure outcome of a cesarean section, and we used to use paper, but paper data is always inaccurate and questionable. So we decided to put in the system. Now the key information in Robinson 10 criteria for cesarean section is the indication. The indication normally is entered by a physician, but in our process, and we have a nurse, we have midwife, and there's no clear accountability to put what is the indication for cesarean section. So through the network, we clearly define accountability. All the indication has to be entered by OB doctor, which will ensure our outcome measure is reliable and meaningful. Okay. Again, care must flow. So this is an example how we implement our unit dose medication administration. The difference we did is the whole workflow is not only clinical process, not only limited to pharmacy, ward, and also point of care. We extended the scope to inventory. So every workflow starts from inventory management. When we receive medication, the process is started. In the next stage, we're going to extend the scope to supply chain. And we have heard from HIMSS the past 2 days in the HIMSS speech talking about how important the supply chain information is. This is going to all the information is going to be part of medical intervention. This is help the overall outcome measure reliable and useful. Okay. This is another example. And even though we are the first organization to implement the primary health care model, but we still have a disconnection between primary care and the specialty care. The reason is in our country, it is our culture. We can always direct to see specialists. We don't have to get a referral letter from primary care. So this disconnection has negative consequence. And quite often, we don't know whether a patient is seeing specialty doctor or not. Even seeing the doctor, we don't know whether what the result is, whether the result going back to primary care or not. So we implement this workflow. The purpose of this workflow is to make sure booking is happening and make sure patient see specialist. The second is once patient seeing specialist, the specialist doctor is going to put a report in the system. It's automatically going back to primary care doctor, and the primary doctor can always to inform patient. This is another example about acknowledge results in the report. And once the results is released and report is complete in the system, they also go back to ordering doctor. So ordering doctor has to acknowledge in the system within certain hours. And we also have a very clear trace record to know who's the follow-up person, whether nurse going to follow up, a clinical assistant going to follow up, or doctor is going to follow up with patient. So this is to ensure there's no information, no important report is missed. Okay. A few QIs, and we put 50 QIs in different clinical domains across all the facility. This is really beauty of the one system. We have 7 hospitals, and every color representing one hospital. The red line is the bar, so we really measure, for example, in emergency, we measure the time from entry to be discharged and from enter emergency to be admitted. And also we measure if patient came with the pain score over 3, what is percentage of about reassessment about pain? And we also measure the time patient have to wait in the emergency to be seen. Medication, we measure reconciliation rate and also measure pharmacist intervention about the physician's prescription. We also see what is the inpatient antibiotic usage and outpatient antibiotic usage. In nursing, we see what is the full assessment completion rate, and the nurse is very cautious about the mistakes. So we also measure what is the mistakes about the drug and mistakes about the lab specimen. Okay. Radiology, we measure reading discrepancy rate, and it has to be less than 5. If over than 5, and there's alert there. And we also measure level A imaging rate, and also what is the retake rate. Retake usually means the first X-ray wasn't good quality. Okay. A few books would like to recommend, and beyond implementation, and also the other one is Quality Chasm. These 2 books really help us to understand when we prepare implementation and what is the journey, how long is the journey is going to be, and what is the most challenging part, and how to prepare implementation. The other book is a more clinical book. One is a checklist written by Arthur. Arthur is a Harvard graduate surgeon, and this book tells us a very clear story. The simple checklist in medical practice going to stop a lot of events and health-threatening events. So I remember I read this book really telling us what difference between specialty. Sometimes specialty need to thinking about include risk. Sometimes they need to think about how to exclude risk. So really remind us when to stop and when to think quality. The other book is about inside the physician's mind. This book really teaches us what doctors think, what is the relationship between doctors, and what is their view about the clinical leadership. Again, medicine is complicated, and disease deaths are very cold. Our physicians using their sympathetic way to practice medicine, treating every patient. And technology is also code. We're talking about the coding, we're talking about the rules, talking about if-then conditions. And we are in the position to understand technology and apply technology in ethical way as well as a sympathetic way, and make change. Okay. Right. Moving forward. This is a smart hospital imagination, and was dreamed a few years ago, but I think this is close to reality, probably near future. Technology everywhere, and we can easily use in China, use mobile phone to get a doctor booking online consultation. And this picture is a little bit dodgy, but it's very milestone talking about the internet hospital in China. Government has released a very clear regulation and allow internet hospital to happen. Okay, 5T, 41% of 5T coverage will happen in China in next 5 years. Okay. This is also interesting about using CT scan to diagnose TCM disease. They scan face and scan tongue to understand what the problem with the patient. Okay. Supply chain, what's the importance of a supply chain in the overall healthcare data? So thinking about where we are here. It's still a long way to go to achieve wellness and personalized care. So our challenges, I think, destination, if we can understand where our destination is, will be very useful. Because nowadays, it's harder to have a fixed plan, harder to have long-term strategic plan. The world is changing so fast, but it's very clear to us. We have to use AI, we have to apply AI for clinical intelligence. You always remember the human elements when we using business and using technology. Okay, finally, I would quickly introduce, this is a barcode we added to our trachea, and the purpose is to getting users' feedback, to understand whether they are happy, what is the recommendation they can give us. So simple, very simple barcode scan help us to connect to our user. Okay, all right, thank you. I hope this is useful.